Video technique for in-office catheter-less echolaser prostate ablation with reduced dose or clear for BPH in a 372-gram prostate. BPH affects 30% of men worldwide, with prevalence rising sharply with age. Managing large BPH remains difficult, especially in elderly patients. Clear BPH, a minimally invasive office-based echolaser ablation technique, allows for real-time ultrasound guidance and immediate voiding without a catheter. This study evaluates the safety, efficacy, and recovery benefits of this new technique as an alternative to traditional surgery. 5 patients underwent clear BPH in the office with IV sedation and a perineal and periprostatic block. Ultrasound-guided transperineal laser ablation targeting the mid-posterior gland regions was performed while preserving the urethra and rectal wall. Care was taken to ensure that we were 1.5 centimeters away from the urethra and far from the rectal wall. A mean amount of 1,000 joules was delivered using a single laser fiber on each side, for a total of 2,000 joules for the whole gland. All patients were then given a voiding trial and then discharged home without a catheter. For the case today, we're going to review an 81-year-old male with BPH and obstruction who previously was treated with prostatic artery embolization, was unable to tolerate alpha blockers, and is being managed with Tadalafil 5 mg daily. He's developed nocturia 4 times per night and a desire for a solution with low morbidity. He had a previous trust prostate sizing that showed a prostate of 372 grams in size. His post-void residual is 46 mLs, and his PSA was 18.8, and he's had 2 prior negative prostate biopsies. A perineal and periprostatic block is initially given. Under ultrasound guidance, a spinal needle is used to deliver the local anesthetic at the base of the prostate near the junction of the seminal vesicle, and then we pull the needle back to the apex of the prostate to deliver the rest of the block near the apex. We use the planning ESI software to plan the treatment zones in the transverse view, as shown here, and we make sure that we place the needle at least 1.5 centimeters from the urethra and far from the rectal wall. We perform longitudinal imaging as well to confirm the location of the treatment. As you can see, this very large prostate, we're well within the prostate. We'll do 1 pullback or 2 to move the fiber back as we're doing treatment to ensure that we get most of the gland with this treatment. A 21-gauge needle access sheath is first inserted, the introducer is removed, and then the laser fiber is carefully inserted under ultrasound guidance. We then carefully pull back the laser fiber to the correct positioning as planned on the previous ESI planning. We now activate treatment with the enhanced flow Doppler mode turned on the ultrasound machine, so you can actually see the tissue reactivity. What's really neat is you can see this tissue reactivity and changes occurring real time while you're doing the treatment, so we can ensure that we're far away from any critical structures. Once we've completed treatment on one side, we'll remove the laser fiber from the access sheath and then insert it on the contralateral side in the same position, and then do treatment on that side as well. Once treatment is fully completed, a total of 2,000 joules, 1,000 joules on each side, we'll then give the patient a voiding trial. We'll fill the bladder up with 500 cc's of saline or water using the Foley catheter that was placed at the beginning of the case. And then once we fill the bladder, we'll then remove the Foley catheter for a voiding trial for the patient once he's recovered from the IV sedation. The average follow-up for these 5 patients was about 1 month. Median prostate volume pre-op was 45.5, ranging from 34 to 372 grams. Median pre-op IPSS was 14.5. Functional outcomes, the median post-void residual decreased from 14.5 to 9 mLs. 80% of the patients reported a reduction in their LUTs based on IPSS. There were no major complications observed. Minor adverse events included hematospermia in 1 patient and transient dysuria in 2 patients. All patients were successfully able to void right after the procedure. In conclusion, clear BPH demonstrated excellent safety and tolerability. all patients voided spontaneously without catheterization after the procedure. Same-day discharge was achieved in all the cases. There were no major complications, and Clear BPH appears to be a safe and effective minimally invasive office-based treatment for symptomatic BPH.